Good afternoon, everybody, and thank you for joining us in this Proffered Papers Chest and Lung session for an hour this afternoon. My name is Arjun Nair, and I am a chest radiologist at University College London. It's my privilege to chair this session with UKIO today. We have 5 presenters, 3 presenting live and 2 presenting recorded presentations, each up to 8 minutes long. Over the next hour, and I'm very happy to have everybody here today. A few housekeeping notes before we launch in. The panel Q&A will take place after all the talks have been completed, so please do engage and write your questions in the questions tab in the live discussions box. As always, the speaker biographies can be found by clicking on the speaker within the session on the screen you are watching now. So without further ado, I'd like to introduce Dr. Gitin Diaz, who is a machine learning engineer at Behold AI. To present augmenting lung cancer diagnosis on chest radiographs, positioning artificial intelligence to improve radiologist performance. Gaten, please.
Thanks a lot, Arjun. So yeah, my name is Gaetan Dissez, and I work as a machine learning engineer at Behold AI. So Behold AI is a company that does artificial intelligence products for medical imaging diagnosis. And I work in particular on chest X-ray. So we are very much focused on delivering the products with the best clinical value. So for instance, we have a product that is able to detect a normal chest X-ray with a very high confidence, a subset of them, and can be used to reduce the workload of radiologists. And we have this product of able to detect suspected lung cancer on chest radiographs, and that's the one I'm going to talk about today, as I'm one of the co-authors of this paper, Augmenting Lung Cancer Diagnosis on Chest Radiographs. So briefly, to give you an overview of what we will cover today, I will explain why we are working on suspected lung cancer, give you an overview of the study, talk about the dataset and the workflows that has been used. Then I will move to the results and try to go shortly in an in-depth analysis. And as a conclusion, I will talk about limitations and future work. So the reason why we are working on lung cancer is that, as you know, the lung cancer is the largest cause of cancer-related death in the world and also in the UK. And to try to face this issue, the NHS long-term plans aims to diagnose 75% of cancers at stage 1 or 2 by 2028. But we are still quite far from this target. As an example, in Southampton, the early diagnosis rate is only 28%. So we believe that the algorithm that we have developed is one of the tools that can help reach this target, and I will explain later why. So a brief overview. So the aim in this study was to understand if the AI could play a role in helping radiologists to detect suspected lung cancer on chest radiographs. And to do so, we had a data set made of 400 images, including 200 difficult cases. As a method, we had 3 FRCR consultant radiologists annotating the images independently. We had also the AI models that has been developed in-house at Behold AI and trained and validated on 200,000 images. So this model actually is able to detect 41 different pathologies, but here we only focus on suspected lung cancer today. And we propose this novel approach of positioning the AI as a first reader before radiologists to send directly patients with a suspected lung cancer into the CT scan pathway. The results that we have found were quite striking because we saw that placing the AI as a first reader was able to reduce the average number of missed lung cancer by 60% at the chest X-ray level. And it also increased the average accuracy of the diagnosis and the agreement rate between radiologists. So I told you we have 400 images. 200 of those images are images of patients with a confirmed lung cancer that has been confirmed via CT or biopsy later, and that can be seen on the chest X-ray. They are actually difficult cases because most of them had been previously missed by radiologists on the chest X-ray. And we have 200 images of patients without visible signs of lung cancer. It's important to note at this stage that we differ from most studies that exist, in which they usually take only normal images versus images with nodules. Here we didn't remove any other findings, which means in our dataset we also have pneumothorax, effusion, consolidations, and it can be even more difficult than that. We can have effusion with a nodule or consolidation with a nodule. So we didn't exclude difficult cases. We also included cases that are more difficult to see, such as nodules in the apex or behind the heart. The workflow, the augmented workflow that we propose here is to place the AI as a first reader. So the AI will read all the images, and all the patients that have an image that shows suspected lung cancer for the AI will directly be sent for CT scan. All the other images are still reviewed by a radiologist that can decide, obviously, to send patients to CT or to other pathways or to discharge them. The results were quite interesting. So if you look at the graph on your right, you have the accuracy and sensitivity of radiologists alone shown by the green markers, the AI shown by the red marker, and the blue markers indicate the performances of the radiologists, the same ones, with the help of the AI. So if you look at the AI alone, you can first see that the performance of the AI algorithm is more or less on the average performance of radiologists. The accuracy is quite equivalent on average. The sensitivity is actually better than 2 of the 3 radiologists, and the specificity is marginally lower. But if you look now at the performance of the radiologists with AI, all the performances have been leveled up, and it was quite striking to us. You have an improved accuracy and sensitivity for all radiologists and also on average. So on average, it's an increase of 13 points of sensitivity, which means that for every 100 new patients coming with a lung cancer that is visible on a chest X-ray, you will be able to detect 13 more patients. And you can also see that there is a standardization of the performances. Like all the performances now are much closer to each other than they were before. In particular, what's interesting is that the lowest performing radiologist in the first place, now with the AI, is better than the best performing radiologist alone. So you can really talk about addressing the health inequalities with AI, as like all the agreements rate between radiologists are much higher now. If we go a bit more in depth in the analysis, we have also shown in particular that the AI was particularly helpful for detecting small nodules. And it's also the situation in which the radiologists have the lowest sensitivity. So here, for instance, for nodules smaller than 2 centimeters, the radiologist sensitivity is lower, but it's also when the AI is helping the most, adding 10 and 17 points of sensitivity. As those small nodules can often correspond to very early stage cancer, that's why I said before that we believe we can really help radiologists detect more of those nodules and detect more patients with an early stage cancer. Another situation in which we think we can be particularly helpful with this AI algorithm is when there are distractors on the image. So when I say distractor, is for instance having a nodule, but also an effusion or also fibrosis. In these situations that are more difficult, obviously, radiology sensitivity is 60 instead of 90 in other situations. And it's when we can improve the most the radiology sensitivity by adding 26 points and bridging the gap between the two situations. Here is an example of what I call a distractor, what I called previously a distractor. So a lot of thing is going on this image. Some radiologists have seen effusion, some others fibrosis, but only one of the 3 radiologists has spotted the nodule that is in the right upper lobe, as shown by the white arrow here, and the AI was able to pick it. So lastly, of course, we had some limitations in this study. So the first limitation was that the data set is not totally representative of real-world situations, as it was not a prospective study, it was a retrospective study. So usually you wouldn't have 200, half of the cases being lung cancers. And we will be able actually to deal with this issue because we recently won a Stage 4 AI award. So we will carry out a large-scale prospective study for lung cancer detection on chest X-rays with our NHS Trust partners. And the other limitation could be that the algorithm in the radiologist could have given the wrong region on the chest X-ray, but have given the correct pathway at the end. Like we didn't focus on the localization of the diagnosis. But we will also, we are currently trying to cope with this problem as we are doing another study, which this time includes the heat maps output for the radiologists, so they would see those kind of heat maps, and they would be able to understand better the AI diagnosis and also to rule out false positives that way. So thanks a lot for attending this session today, and if you want to know more, please do check our different socials, and you don't hesitate to contact me as well and ask questions. Back to you, Arjun.
Thank you very much, Kason, for that very interesting presentation. And as always, just remind delegates to please pop questions into the chat box. We'd love to hear your thoughts and questions. Next, I think we're going to a recorded presentation from Dr. Hugh Walters, who's a radiology ST1 at Oxford University Hospitals, who will be presenting on the improving the accuracy of COVID-19 chest X-ray interpretation through online training.
Hello, my name is Hugh Walters. I'm an ST1 registrar in Oxford, and I'm here to talk about improving the accuracy of COVID-19 chest X-ray interpretation through online training through our novel portal called Rake. As we are all by now aware, COVID-19 has had a dramatic effect on how we practice medicine and how medical education takes place. At time of recording, 170 million cases have been recorded worldwide, with many more going undiagnosed. Because COVID-19 is a novel infection, there are patterns of disease that are not explicitly taught in medical school and within medical training. This means there's been a need to rapidly upskill the workforce in identifying COVID-19 in order to best treat their patients. Because of its infectious nature, COVID-19 needs to be identified early, particularly within the ED setting, where patients are triaged into red, amber, and green categories. While RT-PCR is the gold standard test for COVID-19, it's fairly slow, often taking 24 to 48 hours for results to come back, and it's not available in all settings around the world. Lateral flow tests are in more use, and these have a turnaround time of 30 minutes, but again, there are issues with sensitivity. It's therefore important to recognize that chest X-rays can demonstrate the signs of COVID-19 in about 70% of patients on admission, and therefore combining this with a test like a lateral flow test can be a good way to triage patients who are likely or possibly have COVID-19 infection. The pandemic and the associated need for social distancing have led to some acute educational challenges, with an almost overnight shift to digital environments for education and training. This has led to a decrease in interaction within teaching, as face-to-face tools can no longer be employed. Combining this with the increased working pressures of hospital staff and the fact this is a novel diagnosis with a rapidly evolving knowledge base means that there are lots of hurdles to overcome when trying to educate and train staff in the best ways to identify and treat COVID-19. The challenges of the pandemic provided new opportunities for our online training platform, Rake. Rake stands for Report and Imaging Quality Control, and it's a cloud-based platform for medical education, primarily radiology. It incorporates an inbuilt DICOM viewer and a number of training modules that enables remote access training from anywhere with internet. There are a number of training modules in existence already, such as those on NG tube position and MSK fractures, for example. However, we sought to develop a new module for training in identification of COVID-19. The fact that Rake provides teaching, training, and assessment within a remote, on-demand environment meant that we were in a unique position to develop new tools for training and identification of COVID-19. We aim to create an online, on-demand COVID-19 training resource for ED clinicians, and then to formally assess the impact of this training on both speed and accuracy of diagnosis of COVID-19 and other conditions identifiable on chest X-ray. This was a multi-centre study of clinicians within the Thames Valley Emergency Medicine Research Network, which is otherwise known as TAVRN. It consisted of a pre-training assessment of 30 cases, of which 7 were those with COVID-19. The remainder were a mix of normal and other pathologies. All cases were ground truthed by a consensus of 3 thoracic radiologists, and in the case of the COVID-19 chest X-rays, by RT-PCR. Participants were then invited to undertake a teaching slideshow, compiled again by thoracic radiologists, and a number of training cases in order to better identify COVID-19 on chest radiographs. After completion of the training, they were then able to access a post-training assessment, which again consisted of 30 cases, all previously unseen, with a similar breakdown to those in the pre-training assessment. This is an example of one of the slides of the training modules. In total, candidates were exposed to 60 anonymized chest X-rays over 3 separate training modules. On assessment, participants were then required to identify whether chest X-rays were normal or abnormal, and what the pathology was, as well as localizing an area of pathology by clicking on the chest radiograph and marking it. Rake also allows for a detailed breakdown of statistics, such as average time per case and percentage of cases reported correctly. This is particularly useful for formal assessments for things such as engine tube positioning. 116 healthcare professionals based within A&E completed the initial assessment, with 60 then going on to complete all the training modules and the final assessment. The engagement time was relatively short, with a mean training time of 31 minutes for completing all of the modules. Even through this relatively short intervention, we did see a significant increase in the accuracy of chest X-ray reporting. This slide shows the results for the unfiltered chest radiograph, so COVID, normal, etc., which showed an initial accuracy of 43%, which then rose to an accuracy of 57%, with a mean reporting time that reduced by 19 seconds. Initially, 62% of the COVID-19 containing chest radiographs were identified correctly, which after training rose to 72%. This shows that remote, on-demand training and approaches to medical education can improve both the quality and speed of X-ray reporting, and even a short intervention such as ours, with a mean training time of 31 minutes, can have measurable effects on diagnostic accuracy. Interestingly, candidates were generally struggling when they'd had to diagnose pulmonary edema, often mistaking it for COVID-19. This is likely due to the similarities in presentation with bilateral patchy opacifications, and perhaps they were pre-primed to suspect COVID due to the nature of the teaching and B, the pandemic. There are, of course, limitations to any approach to medical education. Only 53% of our initial participants completed all of the packages. This therefore prevents opportunities for selection bias, and therefore we may have selected for those who had a preferred learning style of remote medical education and lost those who preferred other, more direct learning styles. Further, this is at its core is a simulated learning environment, and therefore the cases selected were relatively high quality in order to best display pathology. It's therefore unclear whether in the real-world scenario of variable quality imaging, this would carry through in diagnostic accuracy. And of course, this only looks at ED clinicians rather than other medical specialties, so there is scope to further assess our training within that. Our results show that this approach to medical education is promising, and therefore we're looking to expand the range of modules and training offered by RAKE, including MSK plain film and fracture imaging aimed at our ST1 registrars. We'd also like to further validate the role of simulated radiology training within medical education and see if this could be expanded out to medical schools, for example. I would like to thank Oxford Hospitals Charity, Innovate UK and Pfizer for their support in developing the RAKE platform. Thank you for taking the time to listen to this presentation. Unfortunately, I'm not available to attend the Q&A session at the end of this, but if you do have any queries, please feel free to email me on the email address on this slide. Thank you very much.
Thank you very much, Dr. Walters. Very interesting and practical presentation there. So next up we have Dr. Hannah Byrne, who's a trainee clinical scientist at Nottingham University Hospital NHS Trust, who will be presenting on radiation doses by beam direction in interventional cardiology. Hannah, thank you for joining us.
All right, thank you very much for that introduction. Hello, I'm Hannah, and I am an STP training in bioinformatics, physical sciences, and I'm going to talk to you about a project that I did with the help of obviously the people on screen as well, regarding radiation doses by beam direction in interventional cardiology. So just a quick overview on what the project was. We wanted to create a data set for the standardized doses that happens at each angle during interventional procedures. And we wanted to do that so that we could help with risk assessment models, because we could use that as an input model. And we want to do it because this sort of data doesn't seem to really exist at the moment. So to do this, we got the patient information for all patients that had at least one chronic total occlusion over the past 2 years, and we decided to look at that as that would be a big enough data source as a sort of first stab at it. So we needed the information from CVIS, so Cardiovascular Information System, which has the patient information so that we could find the people that had CTOs over the correct time period. And then we also needed data from DoseWise, which has the dosing information, and then we needed to match the patient with the dose information. So the first thing we did with this data was we plotted all the dose events on a graph of primary to secondary angulation, and we got this quite nice graph. So you can see that the data points are sort of clustered into 9 areas, so each of these clusters is representing an area in 3D space. And this would make sense, as you would expect that as a cardiologist is going through their procedure, that they would choose a rough area that they can ask their radiographer to target and then move around to sort of fine-tune actually what they're looking for. So the fact that they're clustered is not a surprise. But what we wanted to do with this data was actually assign more formally each data point to one of these clusters. And we did this using the k-means clustering algorithm. So just a quick introduction to what that actually means. So k-means clustering is one of the most commonly used unsupervised machine learning algorithms for dividing a given data set into k clusters. So the aim here is to partition the observation into the number of sets you've told it to cluster it and minimize the variance within each cluster. So, and quickly, the steps that takes. So the first step is to actually tell it how many clusters that you want it to cluster into. And then secondly, you randomly assign a point in each of the clusters to be the center of each cluster called the centroid. You then assign each observation to a centroid based on its Euclidean distance. And then for each of the clusters, you recompute the centroid by calculating the new centroid based on all the data points in the cluster. And then you just iterate through that process until the centroids don't change or the maximum number of iterations has been reached. So that's what we did to our data, and we got this cluster data set. So each of the colors is a different cluster, and the centroids are presented in black in each of the centers. So this is great. Why did we want to do this? So we wanted to find what the average dose area product per procedure per cluster was, and we wanted to find out what that was for both fluoroscopy and acquisition independently. So, and this is because fluoroscopy is more associated with finding the vessel, whereas acquisition was more associated with the treatment on the vessel. So you'd expect there to be a difference in the dosing. And we also wanted to know on average what the percentage dose was going into each cluster, again split by fluoroscopy and acquisition. So the next thing was to basically sort out our analysis pipeline. So we did do the k-means clustering on the whole data set, but we also, as a side experiment, we wanted to split by fluoroscopy and acquisition first to see if there would be a difference in the clustering sets, because we had assumed that acquisition might not have any dose associated with the center, but after talking to the cardiologist, we found out that actually wasn't the case. They do have dose associated to the center point, and that is relevant. So we decided not to split before. We clustered the whole data set, then split by fluoroscopy and acquisition. And then having clustered the data set, you split it between fluoroscopy and acquisition, and then find the average DAP per procedure per cluster by counting the number of procedures, summing the DAP in each cluster, and then just dividing the latter by the former. And then the percentages is just done by calculating the total DAP and then dividing each cluster's procedure average DAP by that. So then we wanted to actually apply it to some vessels. And so to do that, we actually had to look at all of the vessels that were operated on within that 2-year period. So here you can see the list of vessels, but how do we know which one to choose? So the first thing you can notice is actually there's quite a lot of vessels that are treated that have more than one vessel type in the data structure, which unfortunately meant we actually couldn't include that in our analysis, because you wouldn't know what dose was associated to which vessel because they were both structured together. So as a result, the ones we decided to look for were A, ones that were treated alone, and B, the ones that had a reasonable number of procedures that would lead to a reasonable number of events. So each procedure has like about 100 events. So if it says, for example, LAD other has 22 procedures, that actually then had several hundred events associated to that. So we chose the highlighted vessels. So that is the right coronary artery, the left circumflex artery, the left anterior descending artery proximal, and the left anterior descending anywhere else. And just for people like me who are not cardiologists, here's just a picture of the heart, and I've circled where they are. With the left anterior descending proximal is towards the top. It's before it branches off the left main stem, and others are just all other LAD procedures. So we just have a look at the data. I won't show you the whole data set because it's quite large, but just the two tables show the dose data for all vessels, and I've just chosen one, so I've chosen LAD other. So just to show you a subsection, why don't we have a look at the second row for each table, just to give you an idea of why we did this. So you can see the proportion of dose for LAD other is 3 times that, both for fluoroscopy and acquisition, while compared to all for a given angulation. So looking at that second row. So you can see actually that the vessel targeted is very important in the dose given. So it is clear from our data that the majority of dose, regardless of the angulation, is delivered via fluoroscopic imaging modes. So this is showing that optimizing the dose image quality balance for fluoroscopy will have a larger absolute effect than concentrating on acquisition alone. The operators use fluoroscopy when navigating specialist CTO wires through microchannels and across heavily calcified lesions, thus increasing fluoroscopy dose. This is in contrast to standard diagnostic studies where the acquisition element of the total dose is proportionally higher and thus a higher priority for optimization. Generic directions you can see both for all vessels and LAD other. They're the same regardless, but you can see that the doses for each angulation is varied depending on the vessels treated. So just to quickly sum up, we produced a data set that describes the average dose produced during chronic total occlusion cases over the past 2 years at our hospital at all commonly used views, separated by image capture method, so fluoroscopy and acquisition, and the vessel treated. And we envision that this data can be used in a number of different ways, including being used as an input for models to predict the effects of scattering of radiation delivered at different views to staff and patients, to aid in the optimization of protection in high-risk radiation areas. And we also think that these results may be used for staff risk assessments and patient dose estimation. Thank you very much for listening. If you'd like to put some questions in the Q&A, I'll be happy to have a go answering them. Thank you.
And a great simplification, really, of some difficult concepts in that short time. So next, we're going to go to a recorded video, I believe, of from Dr. Pierre Charges, who is a ST4 radiology registrar from the Severn Deanery, who will be speaking to us about diagnostic accuracy of automated CT pulmonary angiography analysis in suspected pulmonary hypertension.
Hello, my name is Pia, a registrar working at the Royal United Hospitals, Bath, which is a specialist pulmonary hypertension centre in England. Over the next 8 minutes, I'll talk you through our study, Diagnostic Accuracy of Automated CTPA Analysis in Suspected Pulmonary Hypertension. The Royal United Hospitals is an Embio Centre for Excellence from which it receives non-financial support. This study was conducted independent to Embio. Pulmonary hypertension is a progressive condition characterised by right ventricular pressure overloading, leading to right ventricular remodelling, dilatation, dysmotility, and ultimately failure. Transthoracic echocardiogram, TTE, has traditionally been the non-invasive screening tool of choice for assessing patients with suspected pulmonary hypertension, although studies have demonstrated variable correlation between TTE and right heart catheter gold standard. Given poor agreement, it is recommended that screening TTE be graded as either low, intermediate, or high likelihood of pulmonary hypertension. TTE parameters which add confidence to a high BSC likelihood of pulmonary hypertension include right ventricular dilatation, with the right ventricle to left ventricle basal diameter ratio, the RV-LV ratio, greater than or equal to 1. This anatomical parameter is readily measurable on CTPA, which is frequently performed as part of the diagnostic workup of patients with suspected pulmonary hypertension. An RV-LV ratio greater than or equal to 1 is widely considered to be suggestive of pulmonary hypertension, with more recent studies demonstrating highly sensitive CTPA-derived RV-LV ratio thresholds for the detection of pulmonary hypertension. Dilatation of the main pulmonary artery, i.e. a diameter greater than or equal to 29 millimeters, and an aorto pulmonary ratio greater than or equal to 1, i.e. the ratio of the main pulmonary artery diameter to the ascending aortic diameter, are also recognized features of pulmonary arterial hypertension, which translate to CT. RV-LV analysis can be measured manually or by an automated machine learning-derived tool. Manual RV-LV analysis is vulnerable to inter- and intra-observer variability, requiring manual selection and measurement of an image slice. Automated analysis, however, is able to process large existing data sets, avoiding variability inherent to visual assessment. An automated machine learning-derived RV-LV analysis tool was shown to have a high level of accuracy when assessing the RV-LV ratio of patients undergoing CTPA with acute PE. The aim of this study was A, to determine the diagnostic accuracy of an automated machine learning-derived RV-LV CTPA analysis tool at detecting pulmonary hypertension in patients with suspected PH referred to our specialist centre. B, to compare the performance of an automated machine learning-derived RV-LV analysis tool with manual measurements of main pulmonary arterial diameter and aorta-pulmonary ratio, and C, to determine whether or not automated RV-LV analysis predicts mortality in patients with suspected pulmonary hypertension. Consecutive untreated patients with suspected pulmonary hypertension referred to our specialist centre who had undergone right heart catheter between June 17 and March 18 were identified. Inclusion criteria required CTPA and TTE to have been performed within 12 months of right heart catheter, and patients were excluded if the CTPA was of non-diagnostic quality. Pulmonary hypertension diagnosis was made using right heart catheter gold standard, as either a mean pulmonary arterial pressure greater than or equals 25 millimeters of mercury, the European Society of Cardiology definition, a mean pulmonary arterial pressure greater than or equal to 20 millimeters of mercury with a pulmonary vascular resistance greater than 3 Wood units, which is the World Symposium of Pulmonary Hypertension definition. CTPAs are performed on a multi-detector array of scanners with standard acquisition parameters, then uploaded to Embio's fully automated machine learning-derived RV-LV analysis software. This utilizes non-gated, contrast-enhanced 3D volumetric CTPA images in a DICOM format with no manual user input or intervention required. The software uses an 18-convolutional layer neural network called ResNet-18 to detect the left ventricle and the right ventricle, identify appropriate slices for segmentation. Embio's RV-LV analysis software has been validated through extensive neural network training, and the segmentation has a very high level of agreement. Furthermore, RV-LV analysis has been shown to have a high level of accuracy when compared with manual measurement when assessing the RV-LV ratio of patients with acute PE undergoing CTPA, and more reproducible than human observers with a perfect intra-class correlation. The software identifies and segments the right ventricle and the left ventricle before defining the interventricular septum using ventricular masks to model the 2D septal line, performing caliper position and measurement. The maximum RV diameter is then divided by the maximum LV diameter to give the RV-LV ratio. 241 feasible patients were identified. Intra-observer variability for automated RV-LV ratio was perfect. Patients with pulmonary hypertension were more likely to be older, female, have high BSC likelihood TTE, an elevated RV-LV ratio, and elevated hemodynamic metrics. The mean automated RV-LV ratio for patients with pulmonary hypertension was 1.37, significantly higher than the 1.09 mean for those with a mean pulmonary arterial pressure of less than 20 millimeters of mercury. There is a significant strong relationship between automated RV-LV ratio and both mean pulmonary arterial pressure and pulmonary vascular resistance, which is moderately linear. Patients were randomly selected into the derivation and validation cohorts without significant differences between the two. In the derivation cohort, the area under the receiver operator curve for automated RV-LV ratio, discriminating pulmonary hypertension, was 0.731. 90% sensitivity was achieved with an RV-LV ratio threshold of greater than or equal to 0.935, whilst best specificity was achieved with a threshold of greater than or equal to 1.385. In the validation cohort, automated RV-LV ratio demonstrated high diagnostic accuracy for the detection of pulmonary hypertension. Using the threshold 0.935 as discriminated from derivation, automated RV-LV analysis was more sensitive for the detection of pulmonary hypertension compared with TTE, although TTE retained a higher specificity. Manual aorta-pulmonary ratio showed markedly reduced sensitivity and specificity for detecting pulmonary hypertension compared with both TTE and automated RV-LV analysis. Furthermore, automated RV-LV analysis correlated more strongly with both mean pulmonary arterial pressure and pulmonary vascular resistance than manual measurement of main pulmonary artery diameter and aorta-pulmonary ratio. In a subgroup analysis of 49 patients with an indeterminate echo, pulmonary hypertension was diagnosed in 73% at right heart catheter. Applying automated RV-LV analysis to this cohort correctly identified 86% of those who went on to be diagnosed with pulmonary hypertension. The survival probability was lower for those with an RV-LV analysis ratio analysis greater than or equal to 1 at all time points, with mean time to death 356 days. All deaths occurred in patients with a ratio greater than 1, although RV-LV analysis was not significant for predicting 1-year mortality, likely due to the small number of deaths in our cohort. To conclude, in patients with suspected pulmonary hypertension referred to a specialist centre, automated RV-LV ratio thresholds have a high sensitivity for both definitions of pulmonary hypertension and diagnostic utility when transthoracic echo is indeterminate for pulmonary hypertension. Manual RV-LV analysis is vulnerable to inter-observer variability, requiring manual selection measurement of an image slice, whereas automated analysis is able to process large existing data sets, avoiding variability inherent to visual assessment. Automated RV-LV ratio correlates strongly with invasive right heart catheter hemodynamic metrics and is significantly elevated in patients with pulmonary hypertension. Although transthoracic echo was less sensitive than automated RV-LV for PH in our cohort, it retains high specificity, therefore is unlikely to replace CTPA as a screening tool. Automated RV-LV analysis could be used to increase or decrease the pre-test probability of pulmonary hypertension in patients with an indeterminate echo. And most importantly, there is the potential to screen all patients undergoing CTPA for pulmonary hypertension, identifying them radiologically as opposed to clinically, with emphasis on earlier detection to facilitate earlier intervention. Thank you very much for listening, and I welcome any questions.
Thank you very much, Pia. Very interesting and a lot to digest there. So our final presentation this afternoon comes from Dr. Miriam Jackson. Miriam Jackson, who's an advanced practitioner, reporting radiographer at the United Lincolnshire Hospital NHS Trust, who's going to be presenting the faster respiratory diagnosis pathway for GP patients, the first 18 months of the pathway. Thank you, Miriam.
Thank you very much for asking me to speak. We've nicknamed this pathway the FRED pathway, so the faster respiratory diagnosis pathway. Before FRED, patients would go to see their GP, would attend the hospital with their request form, have their chest x-ray, and then return home. They would then have to wait for the report to be sent to the GP, with either telephone conversation or call back into the GP to discuss the report. If necessary, they would then need to go on to have the CT, the request being submitted to the hospital, and again have to return home waiting for the report to be sent back to the GP. If it was then necessary, the GP would have to initiate the 2-week wait referral to the chest physician, and the patient would then wait for that referral and go to see the chest physician. So on average, we believe that this took a minimum or an average of 41 days to occur. So the aims of the FRED pathway were to improve the early diagnosis of lung cancer by accelerating the front end of the diagnostic pathway. Initially, we met with the CCG, primary care, secondary care, including radiology and chest physicians. So our shared goals were to improve the patient experience as they move through the faster diagnosis pathway, minimising the unnecessary delays wherever possible, and to improve the performance by reducing times to diagnosis and therefore treatment. The aim was also that to provide the earlier diagnosis, that the chest x-rays would be reported within 24 hours and CT scans would be undertaken within 48 hours of the chest x-ray. And although it wasn't included initially, we wanted the CT chest to be reported and referred through to the chest physicians within 24 to 48 hours after the CT was undertaken. So we commenced this in June 2019. It was sort of suspended during the first phase of the pandemic because we weren't really receiving any GP patients. So we recommenced it in June 2020. Patients were either attending on the specific FRED pathway, or if they'd come on a normal chest x-ray request form and we saw something, then we would upgrade them to the FRED pathway. In 2019, this was just under 150 patients, and then in 2020, it was just under 300 patients. So we reported just over 32,000 GP chest x-rays during that 18-month period. So the aim of reporting the chest x-rays within 24 hours, in the first 6 months we achieved 96%, and in the second year we managed 96% exactly. Some of the delays were beyond our control. For example, one patient had previous imaging at a hospital outside of the MRAD consortium, and we had to wait for the previous images to be imported onto PACS. So in 2019, almost exclusively patients attended the X-ray departments Monday to Friday during the core working hours, and the chest advanced practitioner reporting radiographers covered Monday to Saturday. In 2020, following COVID, we had to instigate an appointment system, so we extended our working day and covered this to over 7 days. Therefore, the chest reporters also changed their working pattern, although in the first 3 months of 2020, we were severely understaffed. The second aim was that CT scans would be undertaken within 48 hours of referral. And in the first 6 months, we achieved this in 53% of patients. And in 2020, we managed 64% of patients achieving that. The main reasons for not achieving this was patient choice. If the reports and the requests were made on the Friday, Saturday, or Sunday, we had no clerical support to arrange the CT scans. If the patients didn't have current EGFRs, we weren't able to do that until they were able to have the blood test taken. And chest x-rays undertaken at our peripheral sites where we didn't have a CT scanner meant that they would have to attend on another day. And very occasionally, we didn't have appointments available for the patients on the same day. The time interval between the CT being reported and going towards the chest physicians was 72% and increased to 77% in 2020. We found a total of 29% of malignancies, 10% with probable or possible malignancy. We found nodes in 36% and possible nodules in 3 patients, equivalent to 0.2% of patients. We found other abnormalities. In October 2020, the chest physicians asked us to review what we were doing with the patients that we had diagnosed as having a normal chest x-ray, and we were asked to do CT scans of those with contrast. So we did 123 patients, and these were reported as normal in 100 patients. We therefore reviewed that again, and it was agreed with the chest physicians that we would now do just a normal CT chest without contrast. This was an improvement for the patient because it meant there was reduced dose for the patient, there was no need for an EGFR, and reduced scanner time. So pre-FRED, the time between referral to seeing the chest physician was 41 days. Post-FRED, the request would come into the hospital, the appointment would be made for the patient, they would have their CT scan and return home. The reports would be sent to the GP and to the chest physician at the same time, and the patient would then be reviewed and, if necessary, see the chest physician. This on average took 5 to 7 days. So the future is that the FRED pathway is going to continue. We're hoping that more patients will have their CT on the same day. It's the first faster turnaround time between the CT report going to triage, and to reduce the time from the initial chest x-ray to biopsy, with an ambitious aim of completing this within 7 days. Thank you.
Thank you very much, Miriam. That's a very helpful overview and review of your experience there. We'll definitely come back to that. So I think we now have our question and answer session. So I'd like to bring our 3 live presenters back on stage. So we've got Gaten Desez, Hannah Byrne, and Miriam Jackson again. So welcome and thank you again for joining us. And I can see that Dr. Hugh Walters and Dr. Pierre Charters have sent their apologies. So unfortunately, that means more time for me to focus on your presentations. I haven't seen yet any questions coming through the chat, so I'm probably just going to kick things off with you, Gaten, if you don't mind. Obviously, you were showcasing a very practical role for AI in almost obviously augmenting the performance of a radiologist, and you mentioned that yourself in the talk. Couple of things I just wanted to focus on were you talked about that specific presentation was in difficult lung cancers, sort of a half data set with difficult and a half with, were they normal scans otherwise, normal x-rays, sorry, otherwise?
Yeah, no, the other ones didn't have any suspected lung cancer, any nodular mass, but they had other pathologies eventually.
Okay, right. Yeah. And the definition of a difficult lung cancer, who decided that? Was that your panel of 3 FRCR trained consultant radiologists? Or?
No, we didn't ask them to give a score or anything like that. I mentioned there were difficult cases because the majority of them were actually missed in the first place on the chest X-ray, and we got it from the hospital records of patients that had taken like CT scan later, and when they came back to the chest X-ray, they saw it could have been visible actually, but it was initially missed by the reader. Yeah.
Okay.
So in that way,
Because
we call them difficult. Yeah. Sorry.
Okay. No, it was just to say, I think you demonstrated quite a good, I know it's going to sound surprising to people on the call, but you demonstrated what was actually quite a good performance of your radiologists, heading over 80%, I think, in sensitivity. And of course, we know from previous studies, we can go as low as 50%. So on the other hand, your radiologists might have been quite sensitized to the fact that these were cases which had obviously difficult bits in them. So it would be very interesting to see in a real world performance where you may actually find more of a role for your software, especially with trainees rather than with consultants. So just wondered what your views are on that, or if you have any experience on that.
Yeah, definitely. You're right. Like the data set was not totally representative. So I think we will be able to show good results. Sorry, in more like a real life data set as well, because that's how we validate our models internally in the first place, and also because we are currently doing a study in which we aim at having a different seniority of reporters exactly to see what would be the difference in helping the different readers, junior or consultant radiologists, or other types of readers. And second, we will be deployed in hospital and conduct this very large scale study without excluding any case and with very real life data going on for like a month. Thanks to this AI award that we had. So I hope that it will be also like a way to make our case stronger. Yeah.
Okay. And out of interest, because it's my job to be a bit skeptical as well, to push the boundaries, what false positive rate of detection per case of X-ray would you say the system currently has? So obviously these were ones where there was a high chance the system would detect something. How about conversely, if you had it, in your data sets currently?
Yeah, so in the case of the study, the specificity of the algorithm was 93. So it means for 100 patients, there were 7 that were false positives. And the radiologist false positive, you can find that in the paper if you have read as well, was the average radiologist sensitivity was maybe around 96. So it was only 3 false positives out of 100 patients. And but I think in the next study that we will do, we will give the reader the output of the algorithm with the heat maps, and so it's going to be easier for radiologists to discard false positives. Whilst in this study, we focused on like a kind of synthetic situation in which the patients would be directly sent to CT from the algorithm positive output.
Okay.
So there wasn't
actually,
in this study there wasn't a possibility for radiologists to view the eventual false positives and to rule them out. Yeah.
Okay. Thank you very much. So I think I can't see any questions yet coming through, so I would definitely ask delegates to please pop them in. Hopefully what I'm asking might stimulate some questions for yourselves. So Hannah, it's been a long time since I spent any time in the cath lab, for sure. But having spent some, it was very interesting to see your presentation. The first thing I'd ask is, obviously, you provided a description and a method for measuring this scatter. I'm totally ignorant here. Is it even something we currently measure or communicate?
So, to my knowledge, no. But just to explain my background, I'm not I'm not a medic. Sorry, that's the one I was after. I'm not a medic. I don't really have a background in sort of working in clinical areas. I basically just do the background. So the people that will be more knowledgeable will that with the co-authors of the paper. I just did the data analysis. But to my understanding, the reason that I was given this project to like the data analysis is because it isn't really something that is looked at the moment, and having this data as an input, then we could in the future do some scattering modeling. And I think that was the point of this paper, was that we knew of someone that wanted to do that, but they didn't have the input data. So I gave it to them.
Okay, and where the if I understand correctly, the K average clustering method that you used, that was a machine learning method, or well, at least there was some machine learning applied to that method, rather. Is that used in some other applications currently, in either in healthcare or even beyond, that delegates might be able to practically refer to?
So, I mean, I don't know of any like off the top of my head, but I do think it like the clustering algorithm is used in things that require things to be clustered with. I won't be the only one to have used it. I think k-means clustering is quite a common one. So I used R to do my programming, and it was basically a one-line command because people will have written that before, because people are using it. So off the top of my head, I don't know of any, but I would be very surprised if no one else was using this.
No, sure. And I mean, one of the things obviously we find when we're doing dose is that actually the data completeness is not great. Sometimes it's improved obviously with dose tracking software, etc. Out of interest, did you find that you needed to impute missing data, or actually you felt this was actually pretty robust, you had all the data you needed?
We mostly had all the data. The one thing that we needed to look at was that there was, so the way that the cardiologists or the radiographers, they take the x-rays as they put their foot on a button, and they step on the pedal to actually make the dose go. And we noticed when we first looked at our data that we had quite a few events that had 0 dose associated with them. So what we thought was happening was that people were just stepping and immediately taking their foot off, but we needed to make sure that that is what was happening. So we had that problem, and once we established that it's just a foot tap, you can get rid of it. All we had to do was get rid of the data. I think we had a slight issue where some of the data was recorded slightly weirdly, but it didn't turn out to be that big of an issue. Basically, the biggest problem was the weird foot taps, but everything else actually was quite nicely laid out. All I had to do was merge them.
And I know it's not your immediate area of expertise, but having looked at the data, what do you think are the next steps to get this to the application?
That's an interesting question. Oh, sorry, I think you might have cut that out there. Sorry, I missed half that question.
Oh, I'm very sorry. No, it was just about what steps you think would be now required to get you to a staff-specific or individual-specific communication of scatter of risk assessment.
So I think the next step will probably be to use this data as the input for scattering models to actually see what that data is presenting. And yeah, I'm not too sure, but I think it would be interesting if if this was more of a analysis that more trusts did. It could be something that could be audited on more of a national level, which would be then interesting. It'd be one way of comparing how different trusts are operating. Are they doing the same sort of things? How are they, using dosing in the same angle for the same vessels? If so, why? If not, why not? So after using it as an input model, the results of that might then give some indication as to where in the cath lab might be worth focusing more of your radiation protection efforts on. And you might be able to then optimize basically how you're protecting like the room and scatter outside the room and onto the people. And the way to do that is to know where the scatterings happen. So that's, I think, what we're hoping could be used, what the data could be used for.
Perfect. Thank you so much. So lastly, Miriam, I was just going to, I still haven't seen any questions come in. So unfortunately, you've got just me poking and prodding here. Really sorry about that. But I was just really fascinated to see the fast respiratory diagnostic pathway in action. So coming to you next, if you don't mind, I might just ask John if he's all right to project you up on the screen. There you are. Sorry, I couldn't see you there for a while. So it was just, I think what would be fascinating to hear is obviously different places have been able to implement such a pathway to different degrees. It would be great to hear your experience of the hurdles you had and what you did to overcome them, frankly.
Well, it took us over a year to implement the Proffered pathway for doing the discussions with the CCG, with the primary care, and to establish how we were actually going to have patients attend and the stages in between, because most of the chest x-rays were reported by reporting radiographers, who was going to do the referral for the CT, how we were going to get the results then to the chest physicians. And with the old 2-week wait, they would get a patient summary as well. So we had to change our request card to incorporate the questions that they'd want on the 2-week wait referrals. So all of that took quite a bit of negotiating and sorting out. Obviously, some GP practices liked it straight away and came on board straight away. We have other GP practices that don't use the new form and just use the original request form. We have to upgrade it. But yes, everybody could see the advantage of it. It was just the practicalities of how we were going to do each step of it.
Okay. And were the patients coming in for their chest x-ray pre-warned via the form or an information leaflet that they may need to expect a CT scan as well?
They were certainly pre-COVID. It was part of the request card that the information to say that they may have a CT was included on that. However, having gone to appointments, patients aren't getting that referral documentation anymore. So patients, we have created a patient video link, video and a GP video with the information on it. In actual fact, most patients just seem to go, yes, okay, I'll go for a CT scan and don't question it. I think I've only had 2 people actually specifically say, why am I having the CT scan? Some of them, I think, already suspect why they're having it, but they don't voice it. We haven't had that as an issue.
It's really encouraging to hear, actually. And I saw that obviously you were asked to look at, and now I hope I got this right, the patients who were referred but had a normal chest x-ray in October 2020. You were asked to look at the diagnosis rates of abnormality on the CT. Is that correct?
Yes. Yes.
Yeah. And you moved to a not to that based on the results of that. Is that right?
Yes. Yes. So obviously I couldn't include this year's analysis so far when I submitted the abstract to that. But in 2021 to the end of April, we had CT scanned 700 patients, of which we had suspected lung cancer or an abnormality in 117 patients, of which we then confirmed or suspected cancer in just under 50% of those patients. And we did 557 patients that we had reported the chest x-ray as normal, but because of the clinical suspicion, they still went on to go for a CT scan. And we have diagnosed 1.4% of those patients having lung cancer. So that was before it was identified on the chest x-ray.
Perfect. Well, that's very encouraging to hear, and I'm really happy to hear that real-world implementation. So I think that brings this session to a close. I'd like to thank all our presenters, both live and recorded again, and thank all the delegates for attending today. And lastly, but not least, thanks to UKIO and our technical team backstage for making everything run as smoothly as possible. Enjoy the rest of your conference. Thank you.